Welcome back, clinical problem solvers, to another special VMR edition. And things are, the usual when Robbie's stuffing his beautiful face with his acai. So we're really excited for today. May I ask the scriber to unmute themselves and say a few words?
Sure. Hello, everyone. My name is Julia. I'm a medical graduate from Germany. And as always, I'm very excited, especially for Friday, because I love hearing your discussions and learn. And I encourage everyone to be very active in the chat because it's so great to learn and discuss and share your thoughts, and there are no wrong ones. So,
Julia,
um,
it seems like the position of that bike hasn't moved. Does that mean you haven't been riding it?
to be honest, I had to borrow my boyfriend's one because it's stuck. We brought a new shelf and it's so huge that I cannot move my bike anymore. It's really sad. So we first have to clean up. But usually I love going by bike each day.
Well, thank you, Julia, for scribing today. Will the person who's doing the teaching unmute themselves and say a few words?
Hi everyone, I'm Patricia, a medical graduate from Cameroon. I'm doing teaching points today and I'm so excited about the discussion. I'm sure it's gonna be it's gonna be on fire today. So glad to be here. I mean, we have a
Patricia,
power team.
do you also speak French?
Yes, je parle français. It's
Wow.
actually my first tongue. Like Cameroon speaks French, so my French is better than my English.
Wow. Can you just say a few words to the audience in French? Maybe something like Robbie is always stuffing his face before VMR.
Of course, I will not say that. I can,
Robbie, you have a lot of
je suis,
allegiance
je
here.
suis très contente. Je suis très contente d'être là et let's go, viens-moi. Like, I'm really happy to be here. Je suis très contente d'être là.
Ah, bien, bien, merci beaucoup, mon ami. And we'll leave it at that. But who's presenting today? If you can unmute yourself and say a few words.
We. That's the only French word I know. I don't know if I don't know if I pronounce it well. Hi, I'm Kiara. I'm what I am. I'm nervous. I'm happy to be here presenting a case. I'm an internal medicine resident in the US. I don't know what else to do. to say.
Kiara, why are you nervous? You've been with us since we started VMR.
Yeah, yeah, I love you. I love VMR. I love CV Solver so much. I'm nervous because this is a very particular case. I was talking to Ravi. He presented in a very particular way, so I will try to present him as similar as he presented here, but not like. Let's see. Let's have fun, as Ravi said.
We appreciate that. And I think that's the best way to present the case because it really mimics, what happened, which allows us to train ourselves authentically to be better clinicians. It's great to see you again, Kiara. It's been a while. Why don't we get the whiteboard up and then Robbie can tackle the first aliquot? Okay, whenever you're ready, Kiara.
Okay. So I may say just the chief complaint because it's very explicit, maybe. So this patient was a direct admission for worsening renal function.
Ooh, what a start. Would you want us to stop here, Kiara? Is that your goal?
Yeah, I
Wow.
would say
Okay.
so because if I keep going, it would be maybe too much detail. So yeah.
No, I think that you've said a few powerful set of words, and I think that as Prof has emphasized on Wednesday's VMR, the context of evaluating a patient is so powerful. And if you think about the lessons that he shared with us, he was reflecting on a case of altered mental status that developed in the hospital, and shared with us how the last words developed in the hospital profoundly shapes his analysis. The first is to overcome the inertia of the diagnostic slowness that happens in somebody who's already been evaluated very thoroughly, and then also to realize the unique complications of being in the hospital with a particular focus on medications and other interventions. And so I will tell you that that general principle applies in this context as well, because in most instances, when we take care of acute kidney injury or acute on chronic kidney injury, which is the latter is probably implied here with your use of the word worsening renal function, implies that there is acute on chronic component, but of course that might not be exactly what's going on. But most of the time, when AKI is a feature of a clinical case, it is not problem number one. That's because if the issue is, as it often is, pre-renal, there's something very far away going on from the kidney, like hypovolemia or the effects of medications. And that is usually problem number one, with the kidney injury recognized as a less important consequence of that. And as is true of post-renal, the abdominal discomfort or the space-occupying process that is compressing on the ureters is often problem number one. And so I would say that the landscape here is very likely different from the landscape of kidney injury de novo. And the probability of a pre-renal disease is much lower, and the probability of a post-renal disease is much lower. Now, those things could be present and could be components of the disease, but they have likely been going on for so long that even if there's a pre-renal component or a post-renal component, they have probably caused enough damage to result in intrinsic renal disease. The best example of this is prolonged hypovolemia resulting initially in pre-renal and then acute tubular necrosis, or prolonged bladder outlet obstruction from BPH, initially causing pure post-renal and then ultimately causing intrinsic renal disease. So I would venture to say that the probability of intrinsic renal disease is close to 100% in this patient. The question is, was there a pre or post that ultimately evolved into an intrinsic renal disease? And versus, is this a pure intrinsic disease component? This is the exact opposite of kidney dysfunction in all comers, where in the majority of cases, there's almost 100% chance, not quite 100, but pretty close, that the disease is pre or post. Just by you saying the words in that order that you're telling us now fundamentally changes the calculus. But let's not get lazy. It's going to be very, very important to make sure that we understand the distant signatures of this disease before prematurely labeling it as an isolated kidney problem. And I'll refer you to the outstanding schema episode of nephrotic syndrome that the team published, where the cardiac clues of the condition were profound understanding. So where am I at? Just to summarize, I'd say intrinsic renal disease is virtually guaranteed. The components of pre and post that might have led into it are important not to overlook. And as we move to clarify where the disease lies, let's not get fixated on it being just in the kidney alone. Any other reflections, Professor, you want to add before we get more info from Chiara?
Man, when I joked that day that Robbie is a poet, but like just go back and listen to that again. That's like poetry. That's so good. Thank you for that.
The powers of acai, Prof. Rez. Maybe I'll convince you to have it more frequently after you visit. Chiara, what do you have next?
I love acai. When I was in Peru, I eat that every single day, and I was about to get poor because of that. So acai is amazing. So basically, you're right. His initial presentation and further workup was delayed because of his initial presentation when he was admitted. So basically, a little bit of the HPI. He had worsening, about 2 weeks, worsening progressive headache, and shortness of breath. Regarding the headache, it was basically holocranial, and he was very uncomfortable regarding that. When I met him, he was a very mad, mean person because of that. Basically that, and regarding the shortness of breath, he was having shortness of breath, both on rest and exertion, basically. Some other review of systems, when I met him, he said he was presented recently with hearing loss and mild abdominal pain. He had arthralgias everywhere, so he was very like uncomfortable on presentation. He was weak and he had like very sleep disturbances as baseline. So to work on his past medical history, the patient was previously diagnosed with CKD stage 3A, HFpEF, basically that. He also had AFib. He had a left appendage ligation, but he was still on Eliquis. He had hypertension, hyperlipidemia. He had a recent hospitalization. His left atrial appendage ligation was complicated with myopericarditis. Also, so he had myopericarditis to OSA and BPH. Regarding his medications, just a few. He was taking Eliquis, Lipitor, and Aldacton. And regarding the family history, he had a brother who was recently diagnosed with AMGAS. And health-related behaviors, he drinks like wine nightly, but denies smoking. And I think that's it. Maybe I can talk about the vitals on presentation, which may be important, just that. On admission, his vitals were notable to be, he was tachycardic and around the 25. His blood pressure was 190/100. Otherwise, he was already 94% on rumor, and otherwise are remarkable. I think I will stop here.
Thank you, Chiara. And can you remind us this patient's age?
I'm very sorry about that. Yes,
No,
he was 80 years old.
80 years old. Got it.
Chiara, don't apologize. I never tell Prof. Rez the age of the patient I present.
He
No,
doesn't. He doesn't give me the sex either, but I assume it's male because they're at the VA. But
yeah.
this is great. And maybe what I could do is dissect the HPI and then leave the rest of the information for Rabih to discuss. And obviously it's going to be so helpful when we have that creatinine and we have a prior creatinine. But already what I'm thinking of is that this patient is 80 years old, probably doesn't have significant muscle mass. So I have to be cautious interpreting the creatinine, knowing that creatinine is a byproduct of muscle mass. The less muscle mass you have, the less creatinine is released independent of EGFR. Therefore, usually the creatinine overestimates the estimated glomerular filtration rate in elderly individuals who have poor muscle mass. And that's when we think about the cystatin C, it's helpful because it's less dependent on muscle mass. Then the question becomes this patient was probably sent by a clinic, like had a lab result. They called them, they said, go to the emergency department. Rabih said in the first aliquot, are there any extrarenal manifestations of the underlying disease that's likely leaving an imprint on the kidney? And when Rabih said intrarenal, what he's referring to is glomerular tubules, interstitium, and those little vessels that run up the kidney, not the ones that perfuse the kidney, but they run adjacent to it where you can have thrombotic microangiopathies. So we have to look at each of these symptoms and ask, can it just be explained solely by the kidney disease? And I just want to say something. Right now, we're rooting ourselves in the kidney being the primary site of pathology that has to be explained by the final diagnosis. We may pivot from here, but I think it's a good operating hypothesis based on the fact that they were sent to the clinic for worsening renal function, though we may pivot as we get more laboratory data. We look at the headache. We say, okay, headache and kidney disease. Is there a link? And then I just reflect, like I've never gone through this exercise, but I just reflect on thousands of patients that Rabih and I have cared for with kidney disease. And headache is just not a common symptom. Like, think about all the reasons we do dialysis, from acidosis to elevated potassium to intoxication to uremia to volume overload, but you don't have headache in the AEIOU mnemonic. And it's just not common. It really isn't. Maybe itch is common, nausea is common, but headache, not so much. That being said, we have to temper ourselves. Headache is not unusual. Headache is not unusual. And a lot of people have a history of headache, or they have some headache when they're feeling sick. All of us may experience this. And so I'm tracking it, but it hasn't become a primary symptom that I'm trying to explain or link to the worsening renal function. And I briefly tell myself, okay, does he have a history of tension, migraine, cluster headache? Or is there any red flags to make me consider a more sinister cause of headache, like a thrombosis, a vasculitis, an infection, a glaucoma, etc.? So I'm putting the headache aside. Then we get to the shortness of breath. Shortness of breath in kidney disease, the most common way that you get shortness of breath is someone can't excrete their urine. And maybe I can just ask Rabih really quickly to interject on. Now I'm planning your interjections. I'm interjecting on myself. What does Joel Toff say about the kidney and the urine and the homeostasis thing? It's really good.
Oh my God, it's the best line ever. The product of the kidney is not urine. The product of kidney is homeostasis.
Thank you. You can mute yourself now. So it's easy to imagine how you can get short of breath with kidney disease. You don't have body fluid homeostasis, and fluid builds up in the lung and you're short of breath. So I'm yet not ready to even put the shortness of breath as a separate complaint. This all may change. Maybe there's a cardiac fingerprint. Maybe there's a pulmonary fingerprint. I don't know. Then we start getting some interesting stuff. Mild abdominal pain. It's mild, folks. I'm not yet ready to commit to it. I don't know if it's part of my problem or not. You see what I'm doing here is I'm trying to see what is part of my problem and what isn't. And I just don't think it's worth investing much cognitive energy yet in the abdominal pain. The arthralgias is interesting. You have to look at the past medical history and see if there's any reasons why this patient would have arthralgias. That's worth a thought. And in the exam, you're going to be looking to see if you can convert that to arthritis or synovitis, because all of a sudden the DDX becomes much more specific than non-specific joint pain. And then Chiara said something about hearing loss. Hearing loss, I wouldn't jump to, conditions that are genetic in an 80-year-old. I wouldn't say, oh, is this Alport's? Is this Fabry's now presenting at the age of? No, I wouldn't. I would say, look, as we all age, we have some hearing loss. How severe is this hearing loss? And is it just sensory neural hearing loss of aging? Or does this guy just have a lot of cerumen in his ear? And this is conductive hearing loss. So I guess I just want to summarize with this aliquot. If we're being authentic in our clinical reasoning, it's not trying to reach a diagnosis and say, oh, it's this esoteric diagnosis. No, it's worsening kidney function. That's where we're rooted in aliquot 1. And the other symptoms, it's hard to know if they're signal or noise. They're very nonspecific, and each of them might be explained by the kidney disease or just by aging, and they're just so common. I would love, Rabih, for you to reflect on that, because I want us to be authentic. Chiara is authentic in the presentation. I want us to be authentic and not be heroes in our clinical reasoning.
Oh, you are my hero, Prof. Rez. That I can't change. The theme of this VMR is going to be you battering me down and me fighting back with roses. Okay. So I have to tell you, I think it's very, very interesting when a patient comes in and says they have a headache and that they're short of breath and they have lost their hearing and they have abdominal pain and they have arthralgia and they have sleep disturbances and their mood has declined and they're feeling grumpy. That's a lot of things to say. And I find it very, very intriguing when somebody is able to say those things and to able to actually get those out and express those out. Because I will tell you, for patients who have such some severe systemic diseases, often they just say, I'm not feeling good. And his ability to muster up all these things, I think, is very, very telling. And my office mate has a rule, which I think is a rule that you should all think about, which is if the patient has a chief concern or a set of chief concern that are more than 3 feet apart, they're probably not the chief concern. There's probably something else going on. So say if somebody says, I have a headache and I have toe pain, you're probably going to be like, I'm not going to be able to find anything today. And that reflection is exactly what Prof. Rez is emphasizing, is it's much, much, much more momentum is gained when a patient puts all the diagnostic weight on a set of symptoms that are either localized anatomically or are medically linked in some way we know to understand. So if somebody says, I have palpable purpura and shortness of breath, even though they're 3 feet apart, you know that they're linked in many very, very concrete ways in the form of the vessels underneath. So I'm right there with you, Prof. Rez. My reflection is the same as yours. This HPI violates the 3-foot rule. And the question is there anything else that connects them underneath? And I think that's where the tachycardia gives you a little bit of pause, because it forces you to say, hold on. If there really is the 3-foot rule, that I should really try to figure out what the problem is, temptation to lull yourself and relax and be intrigued by the patient's ability to be able to focus on so many different things at the same time has to be met by the tachycardia. So that's where I would be at. And honestly, the same is true of the medical history. What 80-year-old person who resides in the United States does not have these conditions? And so the only thing I think of immediate relevance from their medical history is the fact that he has a headache and is on anticoagulation. And so I think that would be something that would change your management initially when you first see this patient, where you would have a very low threshold to get a head CT for the possibility of occult trauma or a spontaneous intracranial hemorrhage. The rest is really all threads that are so common that you need more information on the current HPI to be able to say and find value of them, with the exception, of course, that he recently underwent probably the Watchman procedure, which is the left atrial occlusion, and that's unusual enough that you should be a little bit more primed to use that as a pivot point should the syndrome evolve in that direction. All right, Kiara, we're ready for more information.
Of course. So far a beautiful discussion. And I will go with the physical exam and some initial labs. Basically he looked ill appearing and eyes were normal. His cardiovascular exam, when I saw him, he had like JVD more than 15. It was very distended JVD. He also had some mild abdominal distension. He said his last bowel movement was like 5 days ago. Otherwise, on pulmonary auscultation, it was very clear. MSK, he had 3+ bilateral lower extremity edema, and he had some skin, like I would say just elderly lesions, but nothing very concerning, no petechiae or something like that. Neurological exam was pretty much unremarkable, but when I was in his room, he was able to walk to the restroom, and he was using a walker, and I was like, I saw him a little bit unsteady, so he recently started using a walker like 1 month ago at least, and he was even a little bit unsteady. His gait was unsteady even with a walker. So that's for the physical exam. His heart exam was pretty much unremarkable. Just one soft systolic murmur on exam. Most of my patients have systolic murmur, to be honest. I don't know, but I was very, very soft, and so that. So initial labs, his hemoglobin was 7.7, MCV was 87. Otherwise, platelets and WBC within normal limits. CMP, his creatinine initially was 1.8. He had a total, I'm just going to say like notable labs, he had a lot of labs. Notable labs also, total protein 5, albumin was 1.2. UA was remarkable to 20 RBCs, 18 WBCs. He had a protein creatinine ratio of 1,000 780. So I think I will stop here for now. I don't know if you have any questions. Oh, I think I will add some more information, which I think was remarkable. So I would say the hospitalization course was a little bit complicated with this headache. So when I assessed his gait, it wasn't very normal. So I just was concerned about that. So um, we ordered a CT, and the CT showed that he had like a subacute chronic venous sinus thrombosis, which was much like pretty much resolved when he underwent to that. He had heparin infusion for that. And also his blood pressure was getting better with that. And his hospitalization course was complicated by this very high, like I would say, hypertensive emergency. So he had to undergo to the ICU to receive like Claviprex drip too. So now we'll stop here.
Maybe I can just tackle the exam and pass the mic to Prof. Rez. And I appreciate how authentically you're presenting this, Kiara. I can see how much complexity there is in this case. And I think that if you just look at the physical exam alone, I think you should be very worried. And the first reason you should be worried is whenever you see evidence of heart failure with a JVD in the context of tachycardia, that is an ominous sign that the patient could have impending cardiogenic shock. We obviously learned that the patient does not have a cardiogenic shock by the fact that he was stable and had hypertension instead of hypotension, which makes the possibility that that heart rate being sinus is less likely, and more so the possibility that he has an arrhythmia. And that's when you look back and you see in his medical history that he does in fact have atrial fibrillation. But I would say if you don't know anything more, when you see heart failure and tachycardia, you should worry. And hopefully it's an arrhythmia, which means that the heart is beating at a rate that is not necessarily physiologic and maybe a pathologic process. And so I think that as we talked about earlier, trying to understand what the extrarenal complications of this or the extrarenal signatures of this disease are, there certainly seems to be a lot of evidence that the heart is the problem. And I think that the tension in this case is we already know his heart is diseased. And so is the reason that his heart is worsening now because of heart problems, or is the reason that his heart is working less well is because his kidneys no longer filter as much fluid, and so his heart is feeling the effects of that? And this is a very common tension that we feel in the hospital when somebody has volume overload and has both heart and kidney diseases. How do we try to figure out which one is the lead one? And ultimately, the most powerful test is response to diuresis. So if you diurese somebody and their kidney function completely normalizes, you have then diagnosed congestive nephropathy, and the problem is just in the heart alone. But if with diuresis alone, the patient's volume status gets better, but the kidney function remains low, you can then come to the conclusion that the kidneys were primarily the culprit. In most patients, it's a little bit of both. And here, I would say that the evidence of intrinsic renal disease that Prof. Rez will talk about gives you an early hint that you're probably not going to be able to diurese this patient to a normal creatinine, because the kidney has intrinsic problems in it. But I would say that as soon as you see that, you shouldn't get lulled, because all we know is this patient has heart failure with preserved ejection fraction. And let's remember that that's actually not a diagnosis, that's a syndrome. And many underlying explanations exist for patients having heart failure with preserved ejection fraction. This patient has risk factors for the most common type, metabolic syndrome. He has hypertension, hyperlipidemia. Those might be an ultimate explanation for his HFpEF. But when you have HFpEF in the context of a systemic syndrome, you have to be wary that that may not be the only explanation. So to summarize the exam, he has heart failure. The question is, what's driving it? Is it his kidneys? Is it his heart? Or is it both? And the sum total of the evidence would say that it's probably both. So let's keep our antennae up to hold on to both those things. Mike, to you, Prof. Rez.
Thanks, Robbie. I think there's so much data here that I'd love for you to comment after I discuss it. And Kiara, the protein, just so I know, was it like 17 grams in the 24 hours? Like, I'm not sure what the unit was on that.
Oh, okay. So it was, let me open this. It was milligrams.
Okay.
Yes.
Got it. So this is really interesting in that yeah, this is really interesting because the question becomes, does this patient have nephrotic syndrome or not? And is that our anchor? And it's like also pretty cool because I guess Robbie just shouted out the schema team who did an episode on nephrotic syndrome. In order to diagnose nephrotic syndrome, you really need three things. You need to be losing more than 3.5 grams of protein in 24 hours. And by protein, we specifically mean albumin because the glomerulus, if it's intact, it doesn't allow albumin to leak through. But if you're losing more than the 3.5 grams per day of protein, then your serum albumin drops below 3. And so those are two of the three criteria for nephrotic syndrome: proteinuria, and it doesn't have to just be albumin, proteinuria, and then an albumin that's less than 3, and lower extremity edema. Here, I'm pretty sure that this is more than 3 grams of protein a day. And I say that because the albumin is so low, right? It's so low. Generally, when you're not losing that much protein in a day, the liver can compensate by increasing the level of albumin. But when you lose so much protein in the urine, it overwhelms the liver's ability to compensate. And this is assuming you have a healthy liver. And so I'm actually going to operate under the assumption of a nephrotic syndrome-like state because of this degree of hypoalbuminemia. And I don't really have any other reasons for this degree of hypoalbuminemia, like cirrhosis, like protein losing enteropathy, like a severe inflammatory state where you have albumin as a negative acute phase reactant. So I think you're losing it primarily through the urine. When you are dealing with nephrotic syndrome, which is different than just nephrotic range proteinuria, it's a syndrome. These patients are at risk of thrombosis. They're at risk of thrombosis because they're losing their anti-clotting factors in their urine more so than they're losing their anti-clotting factors and therefore at risk of thrombosis. And it's so interesting. If you get less than 2 grams of albumin, your risk for thrombosis is increased in the context of nephrotic syndrome. Some nephrologists will actually prophylactically start anticoagulation in nephrotic syndrome when the albumin is less than 2. Here it's 1.2. So the risk of thrombosis correlates with the degree of hypoalbuminemia. And this patient was on Eliquis, and despite being on Eliquis, still had a venous clot in a particular location. So it just tells you the degree of hypercoagulability that this patient is experiencing, assuming they were taking their Eliquis. Then you look at the urinalysis. And the urinalysis, this is what we would consider an active sediment. Usually when you're dealing with nephrotic syndrome, you're not seeing so much activity in the urinary sediment, but you can. And immediately when you start seeing red cells, white cells, and proteinuria, you have to wonder, is there a component of glomerular nephritis? Is that glomerulus inflamed? Is it inflamed? Or is there a component of tubulointerstitial nephritis? So the question becomes, where do we go from here? When you're dealing with such severe proteinuria, when you're dealing with an active urinary sediment, where you have if this is actually 1.7 grams of protein, maybe it's on its way, but I can't explain the low albumin any other fashion. And so I'm looking at this overlap between nephritic and nephrotic. And there are a few diagnoses that fall in that overlap. But really, the issue here becomes a kidney biopsy, because the kidney biopsy will allow us to either frame this as a primary or secondary cause of kidney injury. And it's actually really simple how you can think about nephrotic syndrome. And I'm going to show this to you right here. And this is really what my brain is doing right now, is that I came here as far as like when to suspect. We have edema, we have thrombosis. You could send lipid panels too. It's quite helpful. The diagnostic criteria, as I mentioned, is you have to have more than 3.5 grams in 24 hours, a serum albumin less than 3, and edema. And then the biopsy is just, if you remember the lettering, it's like 2 letters first. So it's the biopsy can show membranous nephropathy, minimal change disease, focal segmental glomerular sclerosis, membranoproliferative glomerular nephritis, a cause of nephritic-nephrotic overlap, IgA nephropathy, amyloid. Rabih was referring to heart, kidney. That is a potential link is amyloidosis, specifically AL amyloidosis, and then diabetes. But note, for each of these biopsies, there's primary where there's no secondary etiology, or there's a secondary cause. And the secondary causes are usually drugs, infection, cancer. The only diagnosis you can make of nephrotic syndrome without a biopsy is primary membranous nephropathy, and that's through the phospholipase 2 antibody, and you can diagnose it without a biopsy. So Rabih, where I am right now is that I guess I don't really understand the magnitude of the proteinuria, but to me, I think it is nephrotic. I think the degree of hypoalbuminemia has made this patient hypercoagulable, and despite being on Eliquis, has a thrombosis. And now the question becomes, what's driving the kidney disease? And we have an active sediment. So getting a biopsy and sending your HIV, your Hep C, reviewing the drugs, thinking about cancer in someone who's 80, but then using the heart as another clue to what might be at play, because you might actually be dealing with something like AL amyloidosis. So all this is prompting me to get an echocardiogram, looking for the particular LV strain pattern, sending the SPEP, UPEP, and most importantly, the serum-free light chains, sending those hepatitis, HIV, and then pursuing a kidney biopsy, but knowing you can't do it when the patient's on anticoagulation. So it's weighing those risks and benefits. Yeah, and going from there, I'd love to know, what are your thoughts with the UA and like the degree of proteinuria?
I completely agree with you, Prof. Rez. I have nothing to add. I'm just shocked that RLR CP Solver says you've only done 11% of your kidney modules. That's a lie. You're 111%, my friend. All right, Kiara, like to you.
You're so smart. But okay, I will keep going. So I'll give some further labs. So there are 2 more remaining aliquots. Further investigation revealed an elevated serum Kappa free light chain. It was 63.7 milligrams per liter. There was a Kappa Lambda ratio of 2.2, and a Kappa free light chain also was present in urine. It was 145. He had low complement levels. Basically, C3 was less than 41, C4 was less than 4, and there was presence of cryoglobulins in blood. And as PEP revealed, there was an M spike in the gamma globulin region. And we also sent a serum flow cytometry that showed no evidence of like a lymphoproliferative disorder, plasma cell neoplasm, or increase in blast. Something I was hiding information is just this patient was also diagnosed with MGUS last year. He was just being treated like conservatively, of course. So but his nephrology noticed that his kidney function was worsening. So within this further investigation, he had a bone marrow biopsy like a month before he came to he was hospitalized. So this bone marrow biopsy as an outpatient revealed there was Kappa restricted plasma cells, but less than 10% of cellularity. There was no evidence of amyloid deposition, and also flow cytometry for the bone marrow did not identify like monoclonal B, T, or blast cells, and there was no evidence of myelodysplastic syndrome or non-Hodgkin's or acute leukemia. For the echocardiogram, he had an echocardiogram on admission. It was pretty much his EF was around 55 to 60%. He had a normal systolic function, but he has some left LVH, and I'm trying to find a restraint just to check that, which is very, yes. So the left ventricle strain was negative 15.2%, which with apical sparing, which was also suggestive of cardiac amyloid too. I think I will stop here because after that, after much, we wanted to do a kidney biopsy, but it was delayed for his chronic sinus thrombosis and his untractable like hypertension, and we eventually got his kidney biopsy. So I think that will be the last aliquot. If you don't like, maybe you want any other further information.
You are presenting this superbly, my friend. Chiara, this is excellent. And I think I'll just follow the thread of the kidney and then leave everything else for Rabih to discuss. And really, I just want to focus on the Kappa Lambda. And you said the ratio was 2.2. Is that correct, Chiara?
Sorry, the Kappa Lambda ratio was, yeah, 2.2.
2.2. Okay, perfect. It's when you're, and I learned this from Tony Brew, when you're interpreting Kappa Lambda in the context of kidney disease, you have to be aware that both levels will go up. Both levels will go up, but Kappa is more cleared by the kidney. And remember, Kappa, kidney, while Lambda is more metabolized by the liver, Lambda L, liver. So, for example, if someone had kidney disease and their Lambda was greater than their Kappa and the ratio was just 2.2, but Lambda to Kappa, then I would be worried because that's not what I would expect, because the kidney is not clearing Kappa. Why is the Lambda still so much higher than the Kappa? In this context with kidney disease, usually less than 3 with the ratio of Kappa greater than Lambda is okay. It's not abnormal. It's what would be expected. I think there is other data like the echo and other findings, but with this Kappa Lambda ratio of less than 3 in the context of kidney disease with Kappa being greater than Lambda, it's exactly what you would expect. But I would love to pass the mic to Rabih to tackle the myriad of other data points that Chiara has shared.
Myriad, wow. Oh my gosh, you're on fire today, Prof. Rez. Thank you for that alley-oop, because I think that honestly, yesterday we had our case yesterday was predicated on analyzing the presence of a paraprotein correctly. And I think we are getting an opportunity to do a space learning here. And I think we learned from Chiara that this patient has a paraprotein on the serum SPEP. And I think you just have to take Prof. Rez's qualifier that the serum free light chain ratio is not extremely abnormal and as expected in the circumstance. But we know this person has a monoclonal protein as evidenced by the M spike. And so I think the big picture analysis of when you have a monoclonal protein is to ask yourself 2 fundamental questions. What is the source of this monoclonal protein? And what are the consequences of its production? As we learned yesterday, the source is not always plasma cells. The source can be what's called lymphoplasmacytic cells, which secrete an IgM paraprotein that can eventually go on to form Waldenströms, or lymphocytes, 20% of patients with CLL have a paraprotein. 10%, as we learned yesterday, of patients with diffuse large B-cell lymphoma have a paraprotein. 50% of patients with splenic marginal zone lymphoma have a paraprotein. So the source can be a lymphocyte, a lymphoplasmacytic cell, or a plasma cell. What are the consequences? The consequences can be none, and that's what MGUS is called. We have no idea what the consequences of this, none are apparent. The consequences can be related to the burden of the underlying cells that are actually secreting this paraprotein, either as a sheer number of them, i.e. diffuse large B-cell lymphoma, or lytic bone lesions, or paraneoplastic hypercalcemia. But the most complex consequences are nothing to do with the burden, but with the unique molecular structure of the paraprotein. Just like prion diseases, like your Creutzfeldt-Jakob disease, it's not always about how much paraprotein or prion you have. It's about how it interacts with the environment. And if it folds upon itself in a way that causes beta-pleated sheets, it causes amyloidosis. If it interacts with your von Willebrand's factor in an abnormal way, you get acquired von Willebrand's deficiency. If it interferes with your factor VIII, you get acquired hemophilia. And so in this instance, we know that the patient did not have a tremendous amount of cells in the bone marrow. And so if we are going to invoke any consequences of this paraprotein, it either has to be that there are none, or that there is an idiosyncratic complication, not as a result of the amount of paraprotein, but as a result of its molecular structure. What organs are disproportionately impacted from a paraprotein's molecular structure? The nerves and the kidney. And this has resulted in the creation of a whole new label for the space we are in called MGRS, monoclonal gammopathy of renal significance. The only way we can prove that this protein is causing renal damage is through a kidney biopsy and seeing that it's depositing there. How do we make progress on that? Well, we rule out alternate causes. The presence of hypocomplementemia in the world of a paraprotein analysis is relatively interesting and unusual. It is not expected to have hypocomplementemia in a classic presentation of AL amyloidosis, which would be your leading diagnosis in a patient with nephrotic syndrome who has the apical sparing pattern on their cardiac echo, another feature of AL amyloidosis. So I think we have to tread carefully. The classic association of hypocomplementemia and a paraprotein is called C3 deposition disease, where complement is consumed as a result of a paraprotein that messes with C3 analysis. I'll just keep it more simple, I guess. I think that the temptation to call this AL amyloidosis is understandable, but I would be pretty careful because the hypocomplementemia is relatively inconsistent with that, and the patient could easily have age-related transthyretin amyloid of the heart and a separate independent process affecting the kidney. So I think we're very, very suspicious, Prof. Rez, that this person developed a monoclonal protein, then developed kidney injury. But I think I would be cautious about assuming this is AL amyloid based on the combination of cardiac and kidney disease, owing simply to the presence of hypocomplementemia, which would be pretty unusual, and in retrospect, the hematuria, which is not classically part of AL. And so as a result of that, would be open to the possibility of another form of monoclonal proteins affecting the kidney, with either the echo being a fake out or potentially representative of a different independent kind of amyloid called ATTR, which an 80-year-old man is certainly at risk for. I'm curious what your take on that is, probably. It's a very complicated set of data, honestly. But yeah, I would love for your reflection on it.
I think that was brilliantly discussed, and I'm really happy Kiara brought this case because it's like causing so much tension in my mind, and I love that tension. And when you were speaking, the cryos being positive, and if you're dealing with like a monoclonal gammopathy, you wonder, are you dealing with type 1 cryo? And we know that the common um, sites of pathology with cryo is the skin, the kidneys, the joints, and the nerves. And we have some nerves, we have some joints. Cryo is positive, but I just temper that knowing that cryo might be positive in a lot of folks and mean nothing. But in this context, Robbie, like we don't have a Hep C, we don't have another etiology for a polyclonal gammopathy. So I'm really interpreting the cryos as positive in the context of a monoclonal gammopathy. And are we dealing with cryoglobulinemic vasculitis causing hypocomplementemia, affecting the kidneys? And are cryos going into the joint space? And does this patient really need rituximab or something to decrease the B cells? But before the retux, do they really need 1 gram of methylprednisolone? What do you think about that, Robbie? Cryo?
I think that is an outstanding thought. I'm just going to show you visually for 5 seconds the sheer number of possibilities here that I think none of them are excluded. I mean, just look at this. There are so many of them, including type 1 and type 2 cryo, as Prof. Rez mentioned. There's just so many possibilities. So and the treatment for them is all slightly different. So I think cryo is an awesome thought, Prof. Rez. My advice is just like yesterday, it was very, very easy to get tempted to say, oh, this is multiple myeloma. I think it's very easy to be tempted to say, oh, this is AL amyloid. And I don't know. I think Prof. Rez's pickup on the cryo is probably important to be very cautious of.
And Robbie, AL amyloid with those serum free light chains not being that high, are you viewing this maybe it's like a non-secretory, like how we have non-secretory myeloma, or how do you reconcile that for AL amyloid?
Yeah, it's a very good counter argument, honestly. I think the amount of paraprotein in AL amyloid is often very little because it's all about the structure. So I've read a case or two where the capital lambda ratio isn't super impressive and it takes forever to find this little paraprotein. You may need a UPEP or a urine light chain ratio. But yeah, man, there's so many. Well, this is not a classic presentation of AL amyloid for sure.
I love that. So the active urinary sediment and the degree of serum-free light chains make us cautious, even though the echo is showing that stuff, but maybe that's a fake out.
Agreed.
Love you, Ravi. Let's go, Kiara. Thank you for bringing this case.
This is a very messy case. I'm very sorry. When I got this case, guess what? The first thing I did was to call my bestie Kirtan, and I said like, "Hey, I got this case," and he was tell me everything, and we spoke like 2 hours nonstop. That's amazing. So good experience about that too. But I forgot to mention these labs. So negative labs were negative for NCA, rheumatoid factor, negative ANA, HIV, HBV, and HCV. So I will go with the kidney biopsy, unless you want to comment on those. No, okay. I will go with the kidney biopsy. Not here, here. Okay. And the kidney biopsy, the light microscopy revealed mesangial and endocapillary hypercellularity and capillary loop hyaline thrombi. The electron microscopy, there was irregular segmental dense deposits in the basement membrane, capillary loop, and mesangial matrix with epithelial food processes effacement. So that was basically it, and it was negative for Congo red. They commented on the final diagnosis, but I don't know if you want to comment on that before going to the final diagnosis.
Yeah, Kiara, there's only one person here who's 100% kidney doctor, and that's Prof. Rez. I think he can analyze this kidney biopsy perfectly.
Yeah, I went into that kidney biopsy result with Kirtan like 1,000 times, and they were like very cautious with every single word. But yeah, okay, I will stop.
If I share my thoughts on this, I'm just wasting everyone's time. Kiara, please just tell us what does all that translate to?
Okay, okay. So the translation, so the translation means like he was, of course, having MGERS, but he was having that proliferative glomerulonephritis with monoclonal immunoglobulin deposits called PGMID, um, with apparent overlap of type 1 cryo based on the immunofluorescence results, and also he has the presence of IgG1 kappa 3 plus light chain without lambda staining, and of course, and the negative Congo red. I can repeat it. Yeah.
I'd love to get Prof. Reza's thoughts on this. I'll just share one quick thing with you all, which is that if you read, there's a really good NEJM article on this topic. If you read it, you're going to get overwhelmed. I think the key concept to take from Kiara's fantastic case is that there are a wide variety of consequences of having a paraprotein on the kidney. And if you want to be an expert in this space, it'll require a lot of time and effort. Where I've chosen to be right now is actually just to try to answer one key question. And the one key question is actually, how does my management change based on what the answer is? And there's one key element that goes back to what we talked about, which is what are the consequences of this protein and what are the causes? In some of these diseases, the cause is an underlying cancer, and that radically changes your. So you have to be wary of the ones that are associated with cancer and the ones that are not. And so I haven't turned it into a schema, but I wanted to share with you just so you know what the outcome of this conversation often is there are some that are associated with a plasma cell clone, famously AL amyloid, which carries a 15% rate of multiple myeloma. There are some associated with a lymphoma, which is the immunotactoid version of this. There are some associated with both. And there are others in which you will never, the underlying cause is actually not pathogenic, meaning the amount of cells that are secreting this paraprotein are not high. And so you don't have to do cancer-directed treatment. And so Kiara told us that this is the ultimate diagnosis. So I suspect, and type 1 cryo, I suspect that in this patient, thankfully, they will probably not find an underlying clone of cancer that is releasing this protein. And Kiara gave us the evidence for that. She told us the bone marrow biopsy had less than 10% plasma cells, and the flow cytometry she mentioned a long time ago was negative. So as you read and try to become better at this, if you're interested, you're going to be overwhelmed. It's a lot. But they're actually, in the root of it is one key question. Is there an underlying cancer from a plasma cell or a lymphocyte or not? And I think that approaching it from that perspective can make it a little bit simpler from a very overwhelming space. But I'd love to hear your thoughts, Prof. Rez. Where are you at?
Well, I'm in two places. One is that you're my Kirtan if Kirtan is Kiara's Kirtan. But then two is like, as someone who actually, I don't know that landscape that well, Robbie, the monoclonal gammopathy of renal significance. But what I do know well is how to clinically reason. And if we go back to that first aliquot, we knew we were dealing with worsening kidney function. That exam made us consider that whatever was involving the kidneys was probably may also be involving the heart, or the heart is independently involved based on that jugular venous distension. But if you take kidney dysfunction and you have an albumin of 1.2 in an active urinary sediment, then you know the answer must be in the kidney. And with the creatinine being 1.8 for someone who's 80 years old with red cells and proteinuria, you better bet you got to prioritize glomerular nephritis. And then you can even take that a step further and say, I have to prioritize hypocomplementemic glomerular nephritis, which then puts us in that world of cryo, of lupus, of post-infectious GN. And there's one more key concept here in clinical reasoning, is that even though, the daily protein was 1.7 grams, which is nephritic, You have to remember, this is in the context of kidney dysfunction. This is a spot protein to creatinine ratio. It isn't a 24-hour collection, I don't think. And if anything, you have an albumin of 1.2, lower extremity edema and hypertension. So oftentimes we find ourselves in a place where there's nephrotic range proteinuria, but the syndrome isn't fulfilled. Here we found ourselves in a place where the syndrome is pretty much fulfilled without nephrotic range proteinuria. So what do you do in that context? You have no other explanation of an albumin of 1.2. So this nephritic overlap with nephrotic explains this patient's presentation completely, with the thrombosis causing the headache, the cause of the nephrotic, the cryo causing the joint pain, maybe even some of the hearing loss. And so ultimately, even if you don't know anything about monoclonal gammopathy of renal significance or proliferative glomerular nephritis, which it's my first time hearing, or I've heard it and I forgot it, what you do know is how to clinically reason. This is kidney disease. There's an active urinary sediment. There's an overlap between nephrotic, and we know that the biopsy is going to be the answer. The power of reasoning.
NAR has officially accepted your request to not go in your room and to leave you king of the throne, captain of clinical reasoning, master of all.
One last sprinkle on this is what you said. You're like, wait a minute. And what we've been saying, in an elderly, you can have just hearing loss. That's hearing loss. You can have transthyretin, amyloid, which is underdiagnosed in someone with HFpEF. Maybe there's a little bit of aortic sclerosis. So knowing what to relate and what to explain independently, and just being open and letting the data guide you like a researcher. We don't force anything. If you force it, you can get an error in diagnosis. The data guided us. The albumin of 1.2, the active urinary sediment, the kidney dysfunction said this must be the kidney.
Yo, if you want to listen to any part of that hour, you should listen to the last 3 minutes. That was amazing. Beautiful, Prof. And making it to remove the complexity and make it so fundamentally simple, and to see the heart of this case, it was awesome. I owe Patricia an apology. I will miss your teaching points in French because I got to run to make it to work on time. Prof. I made you the host, as you deserve to be from the very beginning. Look forward to seeing you guys. But really, thank you so much, Julia, for scribing. And I guess special shout out to you, Kiara, for an unbelievable case. Thank you all.
Oh my gosh, I talked so much that I think we lost Patricia. I apologize to the group. Patricia, don't make me look bad. Are you back?
Yes, I'm here.
All
Wow.
right, please break it down for us.
Okay, the discussion was just amazing. I hope I captured the essential. So at the beginning, we talked about the approach to kidney injury. We say that AKI is not usually the #1 problem. We need to look at other things first. It can be a pre-renal syndrome because of hypovolemia, or a post-renal injury because of prolonged bladder obstruction, or a BPH. So it's important for us to look at other organs first before anchoring on the kidney itself. Professor taught us about the importance to not anchor ourselves on the creatinine, especially in elderly patients, because they usually have like low muscular masses. So in this case, what was interesting, it was like we have a lot of different symptoms, and we didn't really know where to look at. Well, we had headache with kidney disease, which is not common. So it's important for us to look for other clues, like other clues in the history, like any history of migraine, cluster headache, any head flags for strokes or vasculitis. In this case, we have shortness of breath and kidney disease, which is also not common. So we need to look for sign of cardiac dysfunction in the history. And when we have heart failure, GVD, and tachycardia, we must think about impending cardiogenic shock. So in this case, we didn't have hypotension. So we had hypertension, which led us away from the cardiogenic shock, but it's important to have that in mind. When we have volume overload.
Could you project the whiteboard?
Hugo, I think we lost Julia, and that's why we've lost the whiteboard. But yeah, sorry.
Oh,
But Patricia, please keep going. This is really, really nice.
okay, so we'll go. When we have volume overload and when we have volume overload, heart disease and kidney disease, we don't really know which organ to look at first. So we can use the diuretic response to lead us. If after diuresis the patient get better and the kidney function are worse, this must be an intrinsic kidney disease. In this case, we have like in nephrotic syndrome, Prof. Rez taught us that we need to have 3 factors to make nephrotic syndrome like a diagnostic. We lose more than 3.5 grams of protein per day. We have hypoalbuminemia less than 3 grams, and we have lower extremity edema. And also, patients with nephrotic syndrome are at increased risk of thrombosis. When we see increased sediment on nephrosis syndrome, this is not usual. So increased sediment, we need to think about intrinsic kidney disease. In this case, we were, okay, at the beginning, we were between, is it an extrinsic kidney disease like hypovolemia or pre-renal or post-renal injury or intrinsic disease? So the increased sediment made us thought about intrinsic kidney disease like glomerulonephritis or tubulonephritis. And we learned that the Kappa-Lambda ratio will usually increase in case of kidney disease, the Kappa more than the Lambda. And monoclonal protein, we need to ask ourselves 2 questions, the source and the consequences. And to make things short, then when we have increased sediment, like if we think extrinsic or intrinsic cause of kidney injury, when we have our labs, if we have increased sediment, nephrotic overlapping on nephritic syndrome, hypoalbuminemia, hypocomplementemia, the response of our question is usually in the biopsy. So we need to do our biopsy. So thank you for having me. Thank you for the discussion.
Patricia, that was a grand slam. Tu es intelligent, très, très intelligent.
Merci.
Thank you so much. Kiara, I don't know why you were nervous. Next to Mark's ureaplasma, I'm sure there's many great cases, but I come once or twice a week. This is just an epic case. And now I'm going to fill that gap in knowledge of monoclonal gammopathy of renal significance, but only after I play some golf, because it's time to go play golf, y'all, and keep doing something I really suck at. Have a lovely weekend. Thank you for this special hour. Julia, Patricia, Kiara, and Robbie. Take care.